Hello, listeners. Welcome back, everybody, to Diversion Insights. My guests today are Calvin Parmiter and Shannan Molnar. Calvin is the System Pharmacy Manager over Diversion and Compliance at West Virginia University Medicine, and Shannan is a Drug Diversion Coordinator for WVU, overseeing several of their sites. Like many organizations with multiple sites, there are some things they do very well across the entire system and other things that they're still working on to be consistent. Resources vary, which is part of the issue, of course. And for sites that have Shannan overseeing things, they, of course, have the benefit of that. So let's start with an overview of your organization. Calvin, can you tell us a little bit about you, your role, and an overview of your organization?
Yeah, thanks for having us today, Terry. We're very grateful to be here with you today. So, like you said, I'm Calvin Parmiter. I'm our pharmacy manager for drug diversion and compliance for the entire West Virginia University Medicine Health System. So, our health system is currently 25 hospitals across 4 states. So, West Virginia, of course, but also Ohio, Pennsylvania, and Maryland. In addition to those 25 hospitals, we also have roughly 17 outpatient community pharmacies, and then several clinics and ambulatory surgery centers also spread across the system that may have their own DEA registrations as well. So, in my role, I oversee the standardization and the systemization of our drug diversion response and investigation processes, as well as our DEA compliance program for that entire health system. I stepped into this role a little over 2 years ago now, with little more than just a vision of what we wanted our team to
Mhm.
look like. Since then, we've added 2 pharmacy technicians to our team with plans and hopes to continue to grow and add to that team so that we continue to do more to guide that investigation of drug diversion as well as the DEA compliance across the entire health system.
Yeah, that's a lot. So two technicians, are they helping you with the sites that Shannan is not over
That's
and
correct.
working? Okay. All right. So Shannan, tell us about you, your journey, and how you got into this role as a diversion coordinator, and what team do you have assisting you?
Well, I want to say thank you also. And I've been a pharmacist for a little over 30 years, and the vast majority of that time has it been in direct patient care. I've worked inpatient, outpatient facilities. I've worked in a specialty pharmacy. And I realized I was getting to the point in my career that I was looking to take on a more administrative leadership type of role. So when this became available, I kind of jumped on it and was able to join a team that was pretty robust and a pretty mature facility already with the drug diversion team here. Um, I began following up with another coordinator, and my team now consists of 2 different techs. These are separate from what Calvin is working with to split the system. And we take care of all of the diversion needs for our 7 clinic hospital area that we do. We're kind of the founding state of West Virginia University Medicine, and that's why we've been lucky enough to have a more robust team than the rest of it is. Calvin's doing all the hard work to get the rest of it put back out there and get everybody lined up with the same things that we're able to do now.
Yeah, so you have two people on your team for a much smaller subsection than Calvin does. All right, yeah,
Yes,
keep
yes,
working
I
on
do.
that.
We definitely we work hard. We have a very high volume of events that we go through each day, but
Mhm.
I'm very lucky to have a great team with me.
Yeah, I think the listeners are always interested in hearing. They want to compare, right? It's like, how can I tell my leadership that I need more people? So how many do all of you have out there? And some facilities seem to have a really nice resource pool and we're envious of them. And then others, it's like, oh my gosh, how do you get done what you need to get done? And the answer is probably, well, we're doing the best that we can, but there's more we'd like to get to, right? Yeah.
Exactly.
Yeah.
Definitely.
So I mentioned earlier, it can be difficult to systematize some aspects of the program. And when we spoke previously, you mentioned it can be particularly difficult at the rural sites, right? So tell us, Calvin, about some of those difficulties that you are experiencing. And I would guess it also adds to the complexity when they're in multiple states because the laws may not be the same either for controlled substances that you're trying to adhere to.
Yeah, exactly. The varying laws across states is just one of the pieces of that puzzle of how do we ensure that these processes work for hospitals of such varying sizes, like I mentioned, all the way down from 25-bed critical access hospitals all the way up to that large site. And I think as health systems across the country, including ours, continue to grow and expand their reach, I think one of the big challenges is determining the breadth of that standardization, what really needs to be standard across every hospital, and then what can vary a little bit, what may be able to have its own localized process. Obviously, in the diversion world, my opinion is that diversion investigations and DEA compliance are some of those pieces that really need to be as standard as possible so that we can be consistent. That's something Shannan and I continually try to drive home with everyone that we work with, is that consistency of your investigation so that you can say, this similar event I treated similarly to all of the other events in the past, so that your processes are the same at each hospital and the same at each event as well. I think those are the big things that we try to work on, and in that, making sure that those processes can work for such a lean staff that you may have at a really small hospital that may not have 24/7 pharmacy coverage.
Yeah.
And you may have that academic pharmacy or that academic medical center that has 24/7 coverage with a large pharmacy team, a large nursing supervising team as well. So how do you right size all of those processes for the whole health system?
Right. Yeah, that makes sense. And I agree with those two main areas, that to be consistent with those. Shannan, so you have talked about doing education with your leadership on how to respond to an incident when you're not on site. That kind of goes a little bit to Calvin's point too, for smaller entities where there's not always somebody there. So tell us about what education you've done. I think all of our listeners probably have some story about a diversion or impairment issue that happened after hours, right? And then they show up the next day or even get a call in the middle of the night and they realize, oh my gosh, there were so many missed opportunities with this situation because it happened at night and nobody knew what to do. So what does your education look like, and what are you trying to engage your house supervisors and the rest of your leadership during those hours?
Well, health supervisor, that's the key word for us here. We do try to provide education both at initial hiring on a yearly basis. We have everybody. We have continuing education modules that we have everybody do. I try to get in front of as many teams as I can, both leadership, clear down to the, just the CAs that are working at the desk, everything like that. We really try to get in front of and make sure we teach them whenever we can. And I think they get a little tired of hearing about me sometimes when I show up again. Please, can I talk to you again? But to your point, to keep everything consistent, a house supervisor is a position that is available 24/7, 365. So we have done a lot of work with them to make sure that we have a consistent process that comes through every single time a diversion event. We have diversion algorithms that we've built, and we've built a couple different ones based on the situation. If you have a found controlled substance that has been, left in a med room, something like that. If you have a missing one, if you have suspected behavior is a concern for somebody. We have these algorithms, and we have trained our house supervisors how to deal with those if we are not there. So each one of these algorithms, the initial point in that is contact the house supervisor. The house supervisor will contact security. The house supervisor can lead everybody to say, okay, this is the condition. Is there impairment with this employee? Do we think there's any signs that they need to have a fit for duty test for them? They have all of this outlined in all of their training, and they actually keep a very, very large notebook with them that has it written down, because obviously this is not coming up, 6 times a night, every night that they're on. And we do keep that updated, and we do keep all of our information in there. So we use that kind of as our source of truth. When anybody asks us, please call the house supervisor. And I try to keep that open communication with them, even on off hours. It's I wouldn't say that I am waiting for every phone call to come every time something happens there, but they know that they can reach out to me at any time, and I can at least get them started in the right direction. And if there are further steps that need to be taken and they're not sure about, they know they can always reach out to me to get there, or Calvin, or whoever's on our team. Really, we really try to make sure we're always available for them.
Okay, interesting. So you mentioned they have a notebook with them. I was going to ask you, where do they go for this? Do they go to the shared drive, or, they have to know where to find it? So,
Yes, it is actually
the-
something that they keep with them currently.
okay.
It is a written one, and that makes it a little bit more difficult because, of course, things change, and if those notebooks don't get updated correctly, that's a problem. But the algorithms that I mentioned before, they follow those algorithms too, and those are all available on our intraweb. You can only access them if you are within a VPN of our system here, but they are continuously updated, and they know that that source is always correct and always the most updated one. So we include that in their training. Please look here if you have any questions or concerns.
Okay. Now, to back it up a little bit, if it happens, they have to be notified. So what kind of education do you do for the managers or charge people on the units to know to escalate to the house supervisor?
That's exactly what we try to get through once with new hires. And again, in CBLs, deodoming that we do yearly for that is that if anybody, it doesn't matter if it's a pharmacy tech, if it's a nurse, if it's someone who works in our environmental services committee, they need to contact whatever leader is currently on the floor. The leader that is currently on the floor is trained to reach out to the house supervisor. I actually am part of the training for all of our new charge nurses that come through. They all have a required training that they have to do. And I get in front of them every single time that they have one of these trainings and say, hey, this is our expectations for you. This is what we need you to do if this circumstance happens. And this is who can help you get to the right place if you need to. And we also show them those algorithms. We say, here, this is where these are located at. Find them, understand where they're at and be able to use them when you need them. Because obviously, in a situation, if there is any concern for impairment with any employee, it is a highly stressful situation for a charge nurse. They need to have something written down in front of them. You can't expect somebody to remember that when there's potentially, a safety issue going on right there in front of them at that time.
Right. I like that you get in front of all of the new charge nurses. I don't think that happens routinely at many facilities. A charge nurse just kind of comes on board. So I think that's great. Calvin, do you or someone else also do that at the other locations?
Not currently, and that's one of our challenges is getting that engagement of all of those other stakeholders outside of the pharmacy department where we live, engaging nursing, those nurse leaders that are obviously already working there, and then how do we continue to get that message to perpetuate to all of those new employees? Obviously, we've got a small team. We can't be on site to educate everybody at 25 different hospitals. So how do we work on that messaging is really our focus right now. We're actually in the process of developing a system education that's standard. So, like those CBLs, computer based learnings that Shannan mentioned, really building one of those for the foundations for every new employee across the entire health system so that they all receive that same foundational education no matter where they start their career.
Yeah, and charge nurses, I don't think they come up as they're needed, right? So it's not like a hiring time for new orientation. I mean, you may have them here and there. So probably hard to keep up with. Do you role play with them at all, Shannan? You've got your algorithms, or do you just leave it to them you read through
No,
the algorithm with them and
I do. I review that. And I think in a perfect world, I would actually be able to set up those things. But I do find, unfortunately, fortunately, I'm very lucky to get in front of these charge nurses every time. Unfortunately, I'm also part of a full day curriculum that they have. And engagement is very hard to keep up with that. So I have chosen to step back a little bit from that and make sure that I'm not keeping them for, 2 hours to explain to them. I could spend all day talking about all the things that are so exciting to me, but not to everybody else. So unfortunately, no, I do not do that. I use our algorithms as our source of truth. And it's really a good way. I think that's, what most people are looking for. They can't retain all of this information they're receiving in the day, but as long as they know where they can find it at to see it again, I think that's the most important part for us.
Yeah, that's true. You overload them too much, then
Mhm.
nothing sticks. Have you had the privilege of seeing the fruits of your labor and a well-coordinated response in your absence?
Yes, I think, and Calvin can speak to this too. I want to say again, what I said from before, I worked into a very mature program, and we are so blessed to have such support with our pharmacy and our leadership here at the hospital. And so before Calvin came on, we really didn't have a strong backup. It was literally my director who would step in for the person who was there. Now that we have Calvin, it's fairly easy to make sure that we're not on vacation at the same time. And there's always somebody who really is living there. And again, it's because of that support of our leadership that we have been able to have positions to fill for that. So I do see that. He has recently had to take over on my vacation. And, when things happen, I know that I don't have to worry about what I'm going to come back to. It's always going to be a good outcome as far as the diversion situations go.
Yeah, Shannon and I definitely try to coordinate our times off so that we're not off at the same time. And neither of us take a whole lot of vacation, obviously, as we're still continuing to grow this team and build our efforts across the system. We work a lot. But we have seen at other system hospitals where I may not be present, initiating that investigation and seeing that engagement from the leadership team at those local sites has been super rewarding for them to assemble their diversion response team that maybe 2 years ago was just a figment. They didn't have a foundation. Nobody knew that they were a part of this diversion response team. And now they've got an email group. They can get the team together. They know what to talk about. They know what reports to run. They know what steps to follow depending on what comes out in that investigation. And I think that's really what keeps us motivated across the system to continue expanding what we're doing and helping these local sites so that they can feel confident in these diversion investigations, because that's what you really need. You need the confidence when you're in this investigation. You don't want to feel uncomfortable going down this difficult conversation that you're about to have with an employee, this difficult decision that you're about to have to make.
Right. Yeah. It's so fun, isn't it? When you see the progress of the facility. Sometimes we get like stuck in the middle and we just don't even notice how much we've accomplished and what we've done. But I think with a diversion program, that's a little bit easier to see where you've come from and how smoothly it is now going, and more engagement and responses from peers and managers. It's not just you looking for, who am I going to audit, but they start to come to you and say, hey, can you take a look at this?
Exactly. That's exactly what we have managed to get to with this. It's a wonderful thing. My voice always says, give us a phone call. Don't worry about an email. Just call us. We have a very responsive team, and we're getting there to that. And it's a very satisfying situation.
Yeah, that's great. Another thing I know that you've mentioned you've done, Shannan, is you have worked on a checklist for significant loss for reporting purposes. And this question comes up a lot. It's not defined what significant loss is. The DEA doesn't define it, which I actually can appreciate in this case, because it can vary. But you've taken the ambiguity out for your facilities. You've defined fairly specifically, I think, of when you're going to. So I want to talk about that when you report. But first, I want to ask, did a particular event prompt you to define this more specifically? Or was it just something you took on to improve the program and add consistency?
This was fairly new in my tenure in this position, so it was a very specific event. We had a loss. There was no concern for diversion. We believed the medication had been thrown in the garbage. The garbage had already been taken out. We couldn't find it anywhere. And then it was a question of significance, of course. So if there's absolutely no possibility of theft or suspicion of theft or diversion, we went into that and we started talking about it. And so my leaders were talking about this. And for the size of my facility, the loss of this medication is not much at all. We were probably we currently had about 400 vials of the same medication sitting in our controlled substance manager at the time. This was a very, very small amount of medication in comparison to how much we used every day, how much we had every day. That said, if you think about the safety considerations of this medication, this amount of medication getting out into the public was a potentially, fatal dose of medication of a controlled substance. And, so even though we were taking the percentages and the ratios and everything else into consideration on whether it was significant, we were not taking into any safety considerations on whether this is significant. And if you go through what the DEA actually outlines for you, they don't really seem to take that into consideration either. They ask if it is, the potential for its diversion, the potential for it to be abused, is it abusable in your location? But it still doesn't really say what is the safety issue with this. So my consideration was, I feel like this is a safety issue. And with the Drug Chain Supply Acts that are coming out now, they can track something a single lot number to, from where it started to my hospital if this medication was found in the public. And that would be a significant event if they found one of my vials of medication out in public. So that's kind of where all this started, is we needed to have a way to, instead of having, a 4-hour discussion on whether this was significant or not every time something happened, how could anybody who was, working for me, working during my time, whether it was me, my leadership, we could all just say, yes, this is a significant loss in this case. So that's where this all kind of started from. And it was actually just for me being so new, I needed to know for my own sake how to handle it each time when it came through.
Yeah. Yeah. While you were talking, when you said, and we discussed it, that's what ran through my head. Sometimes these discussions are like, oh my gosh, this is going on forever.
It was a
Like, let's define this and then not talk about it anymore. Yeah. Okay. So what kinds of things do you have on your checklist? How do you define safety, and what other things do you look at?
We tried to make it very, very cut and dry so that there would be no ambiguity in any of these situations. So I kind of have this set up here in front of me, so I'm going to look over. But the first things we did is we took the considerations that the DEA asked us to have. So if it's not a Schedule II medication, which we know is the most divertible, the highest chance of anything happening, is this specific controlled substance likely candidate for diversion in our area? I.e., is it something that has, been a problem? If there is a pattern of losses, they ask for that too. Has this loss been small losses that become significant? That's another one of the questions. Can the loss of this controlled substance be associated with a repeated out of the ordinary access to these controlled substances by specific individuals? And that's coming right out of DEA recommendations there. And so we have this checklist. Those are the first 4 checklists. And then the final one's the one that we use for our facility to really truly define this significance. If you have 2 or more of these check boxes, if you check 2 or more of these boxes, it's considered significant in our facility. And that final box, the one that I really put in there is, to kind of quote it here, is there a possibility of harm due to the amount of controlled substance if found outside of our institution? To calculate, determine if the actual loss is 5 times or more the max initial opioid naive adult dose as outlined by Lexicon. And that's a lot of words, but I really wanted to put all of that in there so that it was very clear. Do you know what I mean?
Yeah.
Anybody who has any knowledge could go into this one place, find the initial dose, multiply it by 5. We put a kind of little chart down on the bottom for the biggest ones: fentanyl, oxycodone, midazolam, the big guns that we're always seeing there, and saying,
did the math for them.
This amount. Yeah. If it is over this amount, this is a significant loss as far as that goes, because this works even for Calvin's hospitals. Somebody who maybe only dispenses 3 oxycodone in a week, if they lose one, if you go just by percentages, that's significant. But in the reality of the whole situation, maybe not. So this is just something that I put together for us to do it. And again, it's not perfect, but it really helps all of us get together and know that we're being consistent every time we make a report.
Right. How do you define consistency of pattern? Or whatever the word.
That's a little bit tougher. And I think that's something that you're going to have to really do from place to place, individual to individual, because we have a lot of individuals that have very low handling of controlled substances. They don't use them that much. And then we have, of course, people working in ORs and anesthesia who have their hands on these every day. So unfortunately, that's not really something that I can give you a specific thing that would be something that we would use for, for our purposes. But we don't fortunately have that happen so too often. So we don't have to address it as often as we do a single loss at a time. Do you know what I mean? And the quantity of a loss for this.
Yeah, because if it's the same med and like, whoops, where did that one go? This happened 3 months ago, or this happened 6 months ago. It's like, same unit, different units.
Exactly. And Shannan does a really good job. Shannan does a really good job internally tracking all of these. So anytime something comes up missing, she has a log of everything so that she can go back and see, did this unit lose this same medication last week? Or did they lose it 2 months ago? And then start to analyze those trends to help make that decision. So she does a really good job of keeping track of all of that as well.
Okay. Me and Excel, we're real good buddies now. So
yeah, I bet. All right. As you both continue to work on improvements for your program, either in your local area, Shannan, or across the system, Calvin, what are some initiatives that you plan to tackle in the next year?
Yeah, I think the biggest one is the one that I mentioned earlier, that standardized education to get everybody comfortable. Obviously, our team is comfortable, but our team's small. We want to get all of those local staff comfortable with what it means to start a diversion investigation. How do you even go down that pathway? Who do you notify? Who's going to be involved? What kind of conversations are going to happen so that everybody knows all of those so that we can really start to get to the point that folks feel comfortable speaking up, because we know diversion is extremely difficult to detect if you're just looking at data all the time. People speaking up is one of the largest indicators we've found to really catch diversion. So getting folks to feel comfortable that we're going to do something with that information and that there's a defined pathway to use that information, I think is number one. And then along with that education, not just the diversion investigation piece, but getting folks comfortable with what it means to be compliant with DEA. We have to meet those reporting windows of within one business day of for a preliminary notification, 45 days for that DEA form 106. And then along with filling out all of the other forms that we have. If you got to order with a 222, really just getting everybody comfortable with all of those processes. So a big push on education and standardized education across the system is our number one goal over the coming year.
Yeah. And I think, when it comes to education, and we touched on it a little bit when you talked about new employee hiring or new charge nurses, we give them so much information at the beginning, and information on diversion investigations that you've also touched on, that it's not something you do all the time, right? So by the time they need it, like, one, do they even retain it along with everything else? And then two, by the time they need it, do they even remember that you told them anything about how to do this? So it is a challenge. I mean, you want to include it at the beginning so that at least they know it's there. But then when do we reintroduce it? How often do we reintroduce it? Because we do want them, if they don't know what to do, we want them to know where to go to get the information of what to do, right?
Yeah, our intent would be for this to be an annual education. Obviously, again, you do all your annual education at the same time, so you're just going to speed through it like you would anything else. But like
Right.
Shannan has done with the algorithms at her sites, making them easily accessible. Somebody can go online and find those. So if we hammer home where the information is and drive that home rather than just the information, I think that's the key, so that you can just access it at any time and you feel comfortable that you can follow this flow and get through the process.
Yeah. Yeah.
Yeah.
Any suggestions for, go ahead, Shannon, did you have something
Oh no,
else?
he's exactly right. And we have a lot of documents that I don't want to say we gatekeep, but we do have a lot of them, and it's a lot of word of mouth too. Through other nursing managers, I have developed documents on how to interview somebody that's in there, how to interview a patient, how to interview an employee, based on a lot of everyone knows IHFDA has, do you know what I mean, great services and great things out there. And I've taken a lot of the stuff that I've learned there, so I have that. And again, it's a matter of letting them know this information is here. You just have to access it. It is available to you. So, once one person finds that out, they talk to their peers, and they actually, I think a lot more gets done with people talking behind the scenes, not me talking to them, but me talking to one person who talks to their peers. She says, "Oh, they have this great information. You need to reach out. You know what I mean? You need to do this." And I think we learn a lot that way and get a lot of that
Yeah.
stuff distributed that way.
Yeah, and if the organization has less turnover, then you get people on board and then that rolls out. But if you've constantly got new, leadership or managers, then you're kind of starting fresh every time. But that is the key. They need to know there's a program, they need to know there's a process, and then they need to know who to talk to or where to find the process, because they will not remember anything that you've told them about how to do it the first time it happens.
Yeah.
Right. Yeah. Any suggestions for the listeners out there who have larger organizations, including rural and maybe in other states, on how they can approach a more systemization of their program, or things that have worked for you, or just as importantly, things that have not worked for you?
I think the biggest key, especially early on, if you're early in developing, is figuring out who the key stakeholders are, both in title, but then also the name of the person. But if there is turnover, you need to know the title of that position so that whoever comes in behind them can also fill that role. I think the biggest thing we've run into is the issues of siloed discussions and decision making. If you silo everything within pharmacy or within nursing or legal or human resources, wherever that may be, that really can break down the process because the communication, like you've been talking about, doesn't get to the people that need to know. It doesn't get to the person that files the DEA report. It doesn't get to the person that files the report with the board of nursing or the person that does the interview. I think ensuring that all of those are involved from the get-go so that everybody knows their role and who they need to report back to is the biggest key to set yourself up for success. And to ensure that your investigations can be efficient and be productive. And then that also opens the door to help with a culture change and shift the stigma away from talking about drug diversion, from talking about substance use disorder, to make people more comfortable with those conversations as well, so that they don't remain silent or feel like these conversations are too difficult to have. And then eventually get organizations to the place where we are getting people help that they need, getting those people into the recovery and setting them up for meaningful career, meaningful impact throughout their lifelong recovery beyond that. Because obviously that's where we all want to get in the end. Number one in the moment is keeping our patients safe, but we also want to make sure our staff can be safe and get the care that they need as well.
Right. And that makes a big difference for culture too. That's because as word gets back on that. And you talk about communication, it is so important that things are not siloed, even taking things for granted. I was involved in an investigation once and the employee was going to be reported. And in my mind, it was very clear who was going to do the reporting. We talked about it. We hadn't heard anything back, so kind of assumed that they had taken care of business. But I thought, let me just check and just confirm so I hear it and we can close the loop and tie it up with a bow. And the person that I feel like we had assigned to do it said, "Oh no, I thought somebody else was doing that." And it's like, oh my goodness. Okay. So really check in. I mean, here's where check boxes are good, right? Done, done,
Yes.
done.
Absolutely.
Yeah.
Absolutely.
All right. Anything else either one of you wants to share with the listeners?
No, I think we really appreciate you having us on here. Appreciate being able to tell our story and where we're really trying to go. So we really appreciate that, Terri.
Yeah,
Thank you very much both, for your time. And, I think this is a great example of a large organization that sounds like it's doing a lot of things really, really well, but we all have things in our facility where we're just continuing to improve. And there's nothing wrong with that, right? There's nothing wrong with talking about, hey, this is what we're still working on, because we know we have room for improvement, and take the wins and just keep on working to make things better. That's what we do. All right. Thank you all very much. And thank you, listeners, for listening. Please don't forget to like and subscribe. It really does. It's the only way we know you're out there and this content is valuable. And that's why we continue to do it. Okay. Thank you, Calvin and Shannan.
Thank you.
Thank you.
Thank you.